Well, welcome back. We're going to do a second segment now that focuses on vaginal causes of itch. I'm here with Dr. Melissa Mauskar, who's a wonderful dermatologist that's helping us talk about itch today. And I'm Kylie Moss. I'm an OBGYN working at the Centers for Vulvovaginal Disorders. So we wanted to start this segment just talking about different things we see that are causing vaginal itch. So the vaginal itch is very different than vulvar itch, and it has a lot of different causes. Sometimes they can overlap, but often they're very distinct. I think the classic things we see that have often been the only things that people are told can be the causes of itch are infectious causes. And they still are very common, right? Bacterial vaginosis, and usually caused by an imbalance in bacteria and yeast, an overpresence of Gardnerella vaginalis is the most common reason for bacterial vaginosis. And then there's Candida vaginitis, so yeast-related overgrowth that causes vaginal itch. And so when I'm seeing patients that have vaginal itch from an OBGYN perspective, I'm thinking about getting cultures and looking under the microscope to see if there's an overpredominance of bacteria that are adherent to the cells. That's the microscopic change we see in Gardnerella overgrowth, or if there are hyphae or pseudohyphae or buds that are related to yeast. And so what do you see from a dermatology standpoint? Like, how do you evaluate these patients? And
Yeah. So first, I'm so glad that you mentioned going to the microscope because I have so many patients that come in and they'll have 1,000 different samples and tests and microbiomes and
yes,
everything that people look at. And I love just going to the microscope and looking at for those changes because they're fast. You get the results back that day. If the
right.
patient has yeast, and I guess the other thing also to talk about is that a lot of patients like say they have vaginal itching, but really where they point is on their vulva. And a
Yeah,
lot of doctors get that confused too. So I feel
all
like
the
that's
time.
when I come in,
Yeah,
I definitely try to get them to pinpoint exactly where they're having their itching. But
yeah.
under the microscope, I think it's so fun when you see the pseudohyphae for Canada. And so
Well,
I
I
love
started,
it.
I have the way that my office is set up, the microscope is actually right by my desk. And so people we usually get dressed and we have the luxury of like having people come in and talk after we do their exam. And so my new nerdy thing that I like to do is like, do you want to look? Do you want to
Oh
see?
yeah,
Especially when I
I
see
bring
yeast, I'm like,
pictures.
come look, come look.
Yeah,
Oh,
no, I take pictures. And so I take a picture and I'm like, well, we found something very interesting because
yes,
I think, they've been so many of our patients get misdiagnosed as having yeast or just thrown diflucan because they call in with
yes.
symptoms. And so I love actually showing patients like, no, you do have yeast. Here it is.
Here it is.
Those are
I
the
know. It's so pretty.
and yeah, yeah. No, I have a nice collection of microscopic images.
Do you
And uh-huh.
do you take them with your smartphone through the objective? Oh, or do
Oh
you
yeah.
have like a good setup?
No, no, it's
Got
real
it.
simple. You basically just like one of my friends, two of my friends in DermPath kind of showed me how to do this, but basically you just line up one of your lenses and if yours I don't have a very super fancy camera, but if you
Yeah.
have more than like four lenses, then you
Yes.
definitely have to be careful. But you just take one of your lenses and kind of find the
Like the
light.
right focal length.
Yeah, exactly. Well, then you move your camera towards the light until it
Yeah.
the objective so then it can come in informative.
Yeah. I
So
need to practice that because
yeah,
a picture's
practice.
worth 1,000 words. It's
Really
so,
is.
yeah, it's so informative. Yeah. Especially when you see like beautiful yeast hyphae. It's like, okay,
Yeah,
that's very
yeah.
nice. But I mean,
But
now the caveat, I guess, is that I think we're only 50-50 at picking up yeast on microscopy. Like that
oh,
one where
absolutely.
the culture
So you
may
have to
prove
go with
it.
your yeah, you have to go with your clinical instinct, right? And so
Yeah.
a lot of times, patients, if they have yeast in the vagina, then often they also have yeast on the vulva, or they'll get
Yes.
some sort of irritation. Same with
Hmm.
PV or even DIV, desquamative inflammatory
Yeah.
vulvitis, vaginitis. A lot of times patients have this copious discharge, and it's really frustrating and concerning. And that discharge also causes irritation on the vulva. So we see just kind of
Yeah.
red glazed introitus extending out to the labia minora, which
Yeah.
is
It's like
really
a downstream effect. Yeah.
what goes in must come out. Uh,
Yeah. And when you look under the microscope for DAV, you see lots of white blood cells. And it makes a lot of sense that if someone is having a lot of overimmune reaction in their discharge, that would then affect the other tissues that it comes in contact with. Yeah.
yeah. No,
Yeah.
I think that, I do think in the next 5 or 10 years, we'll hopefully learn a lot more about DIV.
Hmm.
Um, I think right now we just don't really understand that condition.
Yeah.
I found really great, well, I mean, there's really great regimens in treating that,
Mhm.
with I personally use clindamycin alternating with either triamcinolone cream or, hydrocortisone
Oh, so you
160.
do every other?
So I compound them together,
Yes.
in, in like a joint cream, but, I think that's historically how I was taught, and recently I've actually, instead of doing that compounded 100 hydrocortisone, triamcinolone is a cheap topical steroid that's actually a little bit stronger than, like, the 10% hydrocortisone,
Sure,
and so
yeah,
I
yeah,
use
yeah.
it to treating my patients with that because for a lot of these, like, compounded suppositories, they have to keep them in the fridge and blah, 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 and I think it's
And they're
really
expensive.
frustrating.
They can be expensive.
They're
Yeah.
very expensive, and so when you just have the clindamycin, cream and the triamcinolone cream, patients are really happy, and it works really well. So
Okay.
I'm exploring some other, things that I don't have follow-up on, but I saw 3 patients last week with DIV, and so I tried, like, a new thing with them too, so we'll have to report
Yeah.
if it's
Ooh,
gonna
I
work.
can't wait to hear. Yeah. We tend to use a combination of estrogen, hydrocortisone, and clindamycin in the compound form.
Yeah. I
We
mean, I
have
always add estrogen back, but
yes.
I like to, kind of decrease the inflammation, and then when I see them back, I
Right.
add the estrogen back because the whole point is to, get their microbiome in the vagina back in balance, and, how I was taught was the best probiotic you can do for your vagina is to get the pH and put the estrogen back in, so
Yes, and it always feels like there is a hypoestrogenic component to DIV, and those people need some sort of long-term estrogen like component, even if you could wean them off like the hydrocortisone or the antibiotic. Like there is this like
yeah.
trifecta of inflammation, low estrogen state, and bacterial overgrowth or oversensitivity to the bacteria that's there that we need to address all three. And yeah, so that's so interesting, the difference, the way that you guys treat it. Yeah. Um, so other things we see that can cause vaginal itch would be so that estrogen part is a nice transition to thinking about just hypoestrogenic states. So things like menopause, things like lactation that can cause a low estrogen state can absolutely cause vaginal itching. And so when we see that, obviously our first move is to recommend vaginal estrogen. There's no lab test that can tell you that someone has a hypoestrogenic state. We're just like not there yet. But usually you can see really characteristic visual changes, things that a thin appearance of the vaginal epithelium, friability, and a pallor, so a pale color, right? Like that pinker, healthier tissue is just not there. It's much paler and much thinner and much more sensitive. And patients will also have pain with intercourse at the same time. So there is like a compendium of symptoms in addition to the itch that you can see.
Most of my patients just mention how dry they feel.
Yeah.
One is like, "Oh, it feels like the Sahara Desert." I mean, they really just comment on,
Sandpaper.
or they it feels irritated. And
Yeah.
whenever someone says irritated, I try to get them to let me know if it's itch or pain,
Yep.
because I think that can be hard, and it's a little different for everyone. But I think that the other things I notice is that you definitely lose a lot of the rugae, in the vagina and also on the vulva. I mean, I think the labia minora, I tell patients that with time, this sags, these sag, and everything down there gets pushed up. And
Yes.
so I feel like, we all often see patients that also have comorbid lichen sclerosis or lichen planus. And I think it can be very distressing when patients, are looking down and they see their inside lips have started to resorb or, have a little bit of midline fusion, but also just talking to patients and letting them know that even if they didn't have lichen sclerosis, these are changes that happen with time.
Yes.
And so
I often tell people, when we're born, our labia minora are very small because we don't have the influence of estrogen. They get bigger under the influence of estrogen after we have after our periods start. And then after periods stop, they can get smaller because you just don't have the hormonal support that you did before.
yeah.
Mhm. Yeah. All right. So I think in terms of vaginal itch, the other things that the one thing I think that's maybe one of the more concerning causes of vaginal itch would be lichen planus in the vagina, and so sometimes we do see that where the inflammation that we might see in DIV is much worse and can cause ulcerative changes and even adhesion from one side of the vagina to the other or one part of the vagina to another, which can really affect sexual function. So that's something that's super important to catch and get someone on a really good anti-inflammatory regimen. I'm curious. So, For your lichen planus patients that you're treating, do you use, we tend to use hydrocortisone, but I understand that you're using triamcinolone for DIV. So I was wondering if you're also using it for lichen planus.
Yeah, I think it really depends on the ease of use for patients too. But I think classically, I would do the hydrocortisone suppositories. And recently, with my last handful, I've switched to triamcinolone cream. It's a little stronger than the 10% hydrocortisone, but drug delivery, lipophilicity, it's a really complex topic, to be honest. And I think the pharmacokinetics and everything is can be quite confusing. I actually
Yeah.
have a colleague who is on faculty at Northwestern, Dr. Patel, who is a PharmD. He and I have been very interested in kind of the vaginal absorption of different products. Um,
Yes.
we're kind of diving a little bit deeper into kind of comparing the compounded hydrocortisone. So
Hmm.
we currently use about a 10% hydrocortisone, which is 4 times stronger than the 2.5 hydrocortisone. And we're looking at that compared to kind of the triamcinolone, which is a newer steroid and has some other modifications to the steroid structure to change its lipophilicity, make it a little bit more potent than the hydrocortisone base model. So
Right.
more to come. I think it's a super fascinating
Yeah.
topic I'm learning a ton about. But I think there's just so much we can do
Yes.
with all these different things. But yeah, I think,
Right.
most of I think vaginal lichen planus patients I see, some do have itching, a lot have pain. And like you mentioned, unfortunately, most of them are caught late when they already have adhesions or stenosis,
Yes.
uh, which is incredibly frustrating.
Yeah, because, if we could just get them on steroids sooner, they would not have progression. Because you see the people who have some scarring and you think could progress, but if you get them on a suppressive regimen, they do not progress. And that's the key, is like having good monitoring, having a good steroid vaginal regimen. I think it's hard because people our patients get spooked about steroids because they think about, systemic effects from steroids like weight gain and appetite and mood. And we're talking about local steroids that aren't going to have as much systemic effect and are really the difference between healthy function and complete progression of a really serious disease. I tell
Yeah.
people that it's almost like you have a vitamin deficiency, but the vitamin deficiency is for a steroid. Like you need it to function. And you would never, if you had, you know, a a vitamin D deficiency, although I know that there's a lot of data coming out about that. But if you had a vitamin deficiency and you needed the vitamin, you would take the vitamin. And here it's a matter of your immune system is overreacting. We need the steroid to counteract that. It's essentially, you have a deficiency in your ability to suppress this immune
No,
system
I love
in this
that.
area.
I love that. I mean, how I explain it, it's really similar. I say, it's not like you when you broke your arm and you wear a cast and then you don't wear that anymore. It's more
Right.
like wearing your glasses or taking your high
Yes.
blood pressure medicine. If you don't
Yes.
do those two things, then you're not going to be able to see, or you may have
Yes.
side effects from not taking your blood pressure medicine.
Yes.
And that's
And it
how we are
stinks.
with
And it stinks
steroids.
to have to use assistive devices. It stinks to have to use a medication, but we also are not at the point where we can wave a magic wand and make this go away. You need medication to fix it.
Yeah, I mean, and I think the one other thing that sometimes can cause vaginal itching that may be a good segue to talking about vulvar things too,
Yeah.
are things like mucous membrane pemphigoid and cicatricial pemphigoid.
Yes.
Even bullous pemphigoid, actually. So bullous pemphigoid is one of the most pruritic conditions, I think, known to man. It happens more often in patients over the age of 50, and you can get these tense blisters kind of all over your body. A
So
lot
it's
of
where
times,
the skin doesn't stick to itself. So these
yeah,
blisters happen, right?
yeah. And a lot of times, actually, patients can start off with just spots that look like hives that are
Okay.
incredibly itchy, and then
Yeah.
they'll get blisters later. But about 20% of patients can also get blisters in their mouth or on their vulva in bullous pemphigoid. So that's one subset. And then there's a whole other subset called mucous membrane pemphigoid that you don't
Yeah.
really get lesions on your skin. It's
Mhm.
really just on the mucosal surfaces like the mouth, the eyes, and the vagina and vulva. And
Yeah.
so this can have really severe scarring consequences, just like lichen planus, and sometimes worse. A lot of these patients actually lose their eyesight from this condition, but
And
it
sometimes
definitely
the
can cause itching.
Yeah, and sometimes itching is the first thing, right? Like it's sort of a silent thing other than the itch. And they see all these people to try to figure out what's going on, what's causing the itching in their mouth, what's causing the itching in their um, vulva, vagina, all the mucous membrane areas of the genitalia, and nobody figures it out until it's later, right?
Yeah, I mean, most of the time it's also pain. So a lot of
Yeah,
patients
okay.
have their mouth involved. It'll be
Yeah.
more like pain from the erosions, but
And there's testing that really has to be done in a dermatologist's office for that kind of condition because you guys have the medium to do the biopsies, whereas it's usually not available in other places. Can you talk a little bit about that? Like how one
yeah,
would
so
get a workup for that?
there's several different ways you can test for it. So for the cicatricial pemphigoid or mucous membrane pemphigoid, you want to get peri-lesional normal skin for the biopsy. And you send that in a Zeus or Michelle's medium, so it doesn't kind of fix the tissue. So you
And
can
so that's a
use
special solution that the biopsy has to be in that isn't available
correct.
in normal places.
Correct. You can order it, but I mean, I think
Yeah,
it's
yeah.
definitely, I mean, it's definitely something that dermatologists have just as part of our routine standard of practice.
Right.
And you do that for a direct immunofluorescence. So that's a biopsy. There's actually a blood test that you can take too for indirect
Oh, interesting.
immunofluorescence. That's a send out, but
Mhm.
that's not as it doesn't pick up this mucous membrane pemphigoid condition as easily. But it's a really good thing actually for pemphigus vulgaris or bullous
Okay.
pemphigus. So there's like blood tests you can do to look for those too.
Oh, so interesting. Yeah. But the best like for to cover all of your bases would be if there's an ulcer, some tissue near the ulcer, but not in the actual ulcer, and have it in this special medium to be stained for direct immune.
Yeah, you can do so. You basically do two biopsies. So one is
Okay.
of the actual spot, the erosion at that
Yeah.
transition zone that goes in formalin. That's your regular biopsy that you do.
Yeah.
And then if you have a high suspicion of an autoimmune blistering condition, that's when you do the DIF, the
Yeah.
direct immunofluorescence that's
Yeah.
perilesional or at adjacent normal skin.
Yeah. So fascinating because that's not something we get trained in OBGYN at all or to think about on the differential. So it's
That's
really,
why collaboration's
I
amazing.
know it's
I
so
feel
important.
like I feel like life would be so much better if we just had a clinic where you have every specialty.
Everyone. Yeah.
Yes. And I mean, I know that there's subsetters, and I know you guys, I think, have like sexual therapy or, I think I would love to be in a center that has, sexual therapists, a urologist, a
Yeah, that would be
urogyn, a
great.
derm,
Yeah.
a gynecologist. I mean, I think that
Yes.
we all work so well together.
No, I know. And it's so enlightening to have interdisciplinary collaborations like this because everybody learns and patient care is furthered for everyone. It's
I
great.
mean, thankfully, I think with a lot of our like big, both with ISWISH and with ISSVD and several of the other like medical communities, I think it's a great opportunity for us to all collaborate and work
Yes.
together. It's been great.
No, totally agree. Well, let's take a pause and then we'll talk a little bit more about like vulvar conditions and we'll be right back.